We're looking at the first installation of what's known as visceral regulation in the neuroscience course. I'm addressing viscerosensory regulation with a very brief review of motor and some clinical correlations. The visceral sensory mechanisms have been ignored for a very long time because they really weren't known. So the motor system, visceral system, which we recognize as autonomic nervous system, is an old construct. Goes back about 100 years. You may have heard me say this. But how visceral sensations are organized were a little more difficult to figure out, but we will fill in the blanks, and in a way, in a very interesting roundabout way, we go through a lot of discoveries that came out of the 20th century. In fact, they span in many ways the entire century. So we will be responsible for all of these objectives as they are listed here, all the way to the identification of what's known as the central autonomic network of neurons that rarely gets attention, even though it's very, very important, but it is hidden. It is very much hidden from direct observation because they are really invisible connections when you start connecting those regions inside the brain. So there will be an important slide to talk about under this here, the central autonomic network of neurons. Some of them will be in medulla oblongata, so we can never ignore our brainstem. It's always in view, just like the hypothalamus and amygdala and all of those areas. They are always in view in a certain way. And then very briefly, I will be discussing a few selected clinical correlations. So we started out with this review that I'm really hoping that you remember. Looking at these neurons identified by the purple arrows as the preganglionic neurons for the sympathetic and parasympathetic outflows as they are known. So we're focusing on these neurons in the thoracolumbar outflow for the sympathetics, and then the craniosacral, right, some cranial nerve nuclei, and then S2 to S4 nuclei have parasympathetic preganglionic neurons. They also participate. So as far as preganglionic neurons, they're in the central nervous system, and of course ganglion neurons, which is the second neuron in this chain, will be in peripheral nervous system in various localizations. You might recall that the parasympathetic ganglia are very close to the wall of the organs, or they may well be embedded in the wall of the organs, whereas the sympathetic ganglia occupy very specific places in the body. For example, the sympathetic chain or trunk, and also some of these prevertebral ganglia that you might recall. So on the motor side of things, this might be our review, but we get to think about these once again when we think about the development of the visceral motor system, because some of our clinical syndromes will reflect this. So on the central nervous system side, which is to say we're focusing on the preganglionic neurons, central neurons. They develop from the so-called VE, or a visceral efferent or motor column, which is a basal plate derivative. So here we're looking at an embryonic rhombencephalon, lower brainstem, an embryonic spinal cord to see their location. So again, it's the basal plate that gives these neurons centrally, and then peripherally, all of our ganglion neurons are derived from neural crest. So the neural crest, which is here, these cells become mobile, as you probably well know, and they migrate into these various places of the body, and they become our ganglion neurons. You may want to keep in mind that even our sensory ganglia, so not just these motor ganglia, but even the sensory ganglia are derived from neural crest. So is the adrenal gland, mind you, if you want to recall that. All right, importantly, two families of molecules play critical roles in the development of ganglia. The G, D, and F family, glial cell-derived neurotrophic factor, via the RET receptor, RET receptor, and this will be important for some of our clinical correlations, and the neurotrophin family, the best known representative being NGF, nerve growth factor, acting via the TrkA receptor. And here's a little blurb about NGF, the discovery of it, some famous scientists, two of them, Levi Montalcini and Cohen, got the Nobel Prize for this, for the isolation of NGF, and curiously, NGF, nerve growth factor, is a target-derived factor that acts in a retrograde manner. So this would be an example of a developing neuron. It's making its axon, finding this peripheral target, right? But it is actually the target that produces NGF, and that will stimulate and support this neuron, protecting it from apoptosis and making these possible, pathfinding, synaptogenesis, and overall survival of the neuron possible via the TrkA receptor. So once again, I'm hovering here. NGF is made by the target. It is taken up and have various effects on the neuron in a retrograde fashion. Remember, the word retrograde is referencing the movement inside the axon. Retrograde is from terminal toward soma. Very good. So at this point, we can really start focusing on viscerosensory mechanisms, as I mentioned before, which eluded characterization for a very long time. Whereas the motor side, the sympathetic, parasympathetic, were pretty well known. The viscerosensory, our knowledge had to catch up in a way. And it turns out that on the pain side of things, visceral pain, there is really not a separate system in ganglia and all the rest that would be just for visceral sensations, but then for physiologic reporting and feedback purposes, there are very specific receptors and feedback mechanisms pointing back to central nervous system. So, fundamentally, the roles of visceral sensations are: number one, to provide feedback for visceral reflexes. Second, to report to higher order centers. Keep in mind that both categories, physiologically, the nociceptive, the pain receptors, and physiologic receptors, naturally will report to higher order centers. And naturally, both of those functionally can close reflex loops, and yet they are separate. So again, functionally, nociception, pain sensation is a phenomenon, and everything else that has to do with the specific function of the organs from which the sensations originate that will go into physiologic. All right? Let's look at nociceptors first. Peripherally, these are of course free endings of the A delta and C fibers, and mainly the C fibers, completely unmyelinated, not unlike the somatic sensory system where we have nociception. So there's really nothing special about visceral pain receptors, just the fact that they are in internal organs, right? We will look at this. They respond to stimuli that are potentially damaging to tissue. And that's the classic definition of what nociception is. It alerts you to potential damage. And these are the source of visceral pain. The visceral pain, which is often referred to an overlying somatic area. We will look at mechanisms of referred pain, or at least one of the suggestions, one of the hypotheses as to how referred pain can develop. We will look at that. So these are the nociceptors, visceral pain. And for the physiologic receptors, we will be looking at A, B, C, and D, 4 different subtypes with their own characteristics. A is the rapidly adapting mechanoreceptor type. So see that A and B are both modified mechanoreceptors, right? The rapidly adapting is a so-called cough receptor. So rapidly adapting meaning that their stimulation is instantaneous and very, very fast. And they don't keep reporting that signal. It's instantaneous. For example, when there needs to be a quick reaction such as cough, these receptors are engaged. Whereas under B, the slowly adapting mechanoreceptors, much like in the somatosensory system, stretching of the skin. Now here, we're thinking of stretching of internal organs. And they will confer that fullness of the stomach or urinary bladder, may be giving rise to the afferent arm of visceral reflexes for the emptying of the bladder, for example, and GI tract. So all of these, the slowly adapting mechanoreceptors, fullness and stretching. And then under C and D, we have specialized receptors, the baro and chemoreceptors, and then D, internal receptors. They're not in periphery, but they're in the brain. Because everything else we have talked about so far were in the periphery. So let's look at C, the baro and chemoreceptors. Baroreceptors, aortic arch and mainly carotid sinus, afferents. This is a situation where the nerve terminals surround the adventitial layer and the collagen fibers, elastic fibers of vessels. And these modified mechanoreceptors will sense that type of stretching, meaning elevated blood pressure. And that, using this ganglion cell, it's mainly with the glossopharyngeal nerve, is then translated into the central nervous system at the level of the nucleus of solitary tract. But both of these, the chemoreceptors too, will find their central termination in nucleus of solitary tract. So I'm hovering here as a main hub for visceral sensations, not surprisingly, the nucleus of solitary tract. But for the chemoreceptors that are in the carotid and the aortic bodies, the glomus, as it's often called, up here, these cells, the cells themselves, are sensitive to acidity, hypercapnia, hypoxemia, so things that will signal that we need some kind of counter-regulatory mechanism to restore homeostasis. We're low on oxygen, too high on CO2, and these cells then engage the nerve terminals that are again attached to a ganglion, and central termination goes into nucleus of solitary tract. So we have a common central nervous system hub for that, where I'm hovering. But all of these are still part of the periphery. Now for the internal receptors under D, these are so-called internal receptors because they are inside the brain. They may be in the hypothalamus and or circumventricular organs, and in addition to that, a very unique space and place where I'm hovering near the pyramidal tract, but that's just for our localization reference, the ventral aspect of medulla oblongata, hypercapnia. Sensitive neurons would be here. I mentioned this under the central regulation of breathing. But then we can look at all the others that are in circumventricular organs or in hypothalamus. What are they? Internal chemoreceptors in hypothalamus. And then the ventral surface of medulla, area postrema. That's one of our circumventricular organs. Osmoreceptors, OVLT. You heard that under the hypothalamus topic, OVLT, organum vasculosum of the lamina terminalis. A subfornical organ, similarly. So water, salt balance, and within hypothalamus itself there are internal chemoreceptors. And then finally the internal thermoreceptors. They are in preoptic area. They are in preoptic area of hypothalamus, sometimes called an anterior hypothalamus. Preoptic area is more appropriate anatomically to say. So preoptic area of hypothalamus participating in the sensing part of thermoregulation. So they sense the temperature of the blood perfusing this region of the brain. Some neurons in the preoptic area are sensitive to warm, others are sensitive to colder temperatures. Very good. So we're stepping back a little bit to a bird's eye view of some of our viscerosensory fibers, because I mentioned that this was an enigma for a very long time, how they run, and we need to talk about them. We need to understand also in terms of referred pain, and it has some important characteristics. So obviously, viscerosensory afferents, because they are afferents, see along these arrows, the information is traveling toward central nervous system. So obviously, the information is going toward a brain and spinal cord. And of course, as we settle that, as opposed to the motor impulses that will go out, we can say that pseudo-unipolar primary afferent neurons in DRG, dorsal root ganglia, will be responsible. That's, of course, for the pain component. And then certain specialized ganglia on the head that are not depicted here will be important as ganglia. And I already mentioned some of the ganglia associated with glossopharyngeal nerve in some of the previous slides. Okay? Just to distinguish between the nociceptive and the physiologic receptor impulses. Since there is no unique separate viscerosensory pathway, if you will, in the periphery, these fibers need to run somewhere, quote, all right? It is good to know that some visceral efferents run together with the parasympathetic motor fibers and others run together with the parasympathetics. All right? It is very important to note, once again, that the impulses are going toward the central nervous system because these are efferents, but they use the same nerves and the same routes as the motor fibers. They're embedded in those plexuses and bundled. So having said that, here's an important point, really important point. Efferents responsible for reflexes and those organ-specific monitoring functions tend to run together with the parasympathetics. These are not shown in this illustration. Visceral pain is shown in this illustration. So what do I have in mind? We already had an example of the glossopharyngeal nerve and the vagus reporting from carotid sinus and carotid body and all the rest. And the reporting activities of fullness of the stomach, the vagus has afferents and efferents, right? Now we're thinking about the afferents. What are we thinking? They are running with the parasympathetics, okay? Please don't get confused between motor and sensory. They run together, right? That's why some of our nerves are mixed in that sense. All right? Are you okay with this? You're okay with this concept? Afferents responsible for reflexes and monitoring activities tend to run with the parasympathetics. And I gave you vagus glossopharyngeal nerves as really large examples. However, pain afferents from viscera, and this is what we have here, tend to run parallel to sympathetic innervation. Of course, what's grayed out here, these are all the motor ganglia, right? They have nothing to do with sensory, but the sensory fibers run along, right? That's typically the nociceptive fibers run along this route. But in a retrograde fashion, they will terminate in central nervous system. Of course, we have our dorsal root ganglia as sensory ganglia for visceral pain, just like we had them for somatic pain, right? And this will be very important for our thinking in terms of referred pain from these specific areas of the body. There is one exception, because there is always an exception, below the so-called pelvic pain line, which is pretty much anatomically under the attachment of sigmoid mesocolon, and so pelvic viscera would be in this category. Pain fibers from those areas run together with the parasympathetic pelvic splanchnic nerves, right? So remember the craniosacral outflow for parasympathetics on the motor side. Now we're in these very low segments of the body. So-called below pelvic pain line, nociceptive fibers run along pathways established by parasympathetics rather than sympathetics. Once again, big warning here, do not confuse motor and sensory. We are only discussing sensory. That's why this was such a big enigma for a very long time. But clinically very important, because we get these typical localizations of really a false localization of pain arising from a visceral organ referred to an overlying somatic area based on the identity of the segment where the dorsal root ganglia are, right? Because our hypothesis regarding referred pain is that the pain afferent is giving a collateral to central neurons in the dorsal horn primarily that would otherwise get somatic afferents. And there is signal mixing, so to speak, a crosstalk between somatic and viscerosensory pain pathways, right? So this, the red cell should not be talking to the blue, right? But one of our hypotheses that it is. And here's an example, the cardiac pain, very, very important to recognize, appears in T1 to T5 levels because that's where those dorsal root ganglia are that receive this on the afferent side. May involve C8 as well. So look at these, the somatic afferents are coming in, but we are interested in visceral pain from the heart, So peripherally they run separately, but as they get very close to the dorsal root ganglia, and then past the dorsal root ganglia, the central termination, there might be signal mixing here in laminae 1 and 5 of our spinal cord. And that may well be the basis of referred pain, and now via the spinothalamic tract or anterolateral system, we're looking at this ascending projection here to thalamus and then the corresponding areas of post-central gyrus. Very good. So what have we done so far? We have categorized our visceral afferents. We agreed that we had nociceptors and also physiologic receptors, right? We talked about these. We talked about the intricacies of nociception, high-scarid, and also the various classes of physiologic, meaning organ-specific receptors, right? Now we can talk about more of the integration of this signal. So for organ-specific responses, once again, it has nothing to do with visceral pain. Okay, these are organ-specific responses. So for example, beta and chemoreceptor, as I mentioned before, and also GI tract. So those are running in the vagus. Of course, the central termination of all of this is in the caudal part and medial part of nucleus of solitary tract. So look at this visceral sensory input, which is organ-specific responses from these territories. So think beta and chemoreceptor and vagal responses from thoracic and abdominal viscera. The central termination of all of that is in nucleus of solitary tract. And the nucleus of solitary tract, as I mentioned, is a hub that can talk to higher portions of the brain, and it can also talk to lower parts of the central nervous system, meaning spinal cord. So you see the two ways that the information can go from that point. And of course, there's even higher order that we'll be pointing down here, just hinting at that larger central autonomic network of neurons, one of which, of course, is in hypothalamus, as you just heard, but we'll come back to that. Now, having said all this, the brainstem and spinal cord, and particularly the thoracolumbar outflow in IML, intermediate lateral subcolumn, they play a very unique role, and so important that we'll still have to recognize it in its own right. So hypothalamus and cortex, insular cortex, other parts of the cortex, even prefrontal, have profound influence on cardiovascular function, but the brainstem is really critical. And there are two levels, an upper and a lower level of the medulla. You see the open medulla, you see the closed medulla at obex or below. You see the difference between the two. We need to identify the players. And this is something we've learned in part under brainstem, of course, nucleus of solitary tract on the afferent, the sensory side of things. And it's elaborating a response, sending it to motor and premotor centers, which is going to be the rest. So think about it in those terms. NTS, sensory and organizing center, everything else, motor and premotor. It's a good way of thinking about this. And now we can identify them. Nucleus ambiguous, of course, is recognized. And the RVLM, rostroventrolateral medulla, is such a multifunctional area that is so nondescript that you would never think that really important things are there. We talked about the pre-Betzinger neurons already, right? So then that would be a group of neurons regulating breathing. Well, here we have a pressor region. And we also have norepinephrine neurons projecting up to spinal cord and projecting down, up to hypothalamus and down to spinal cord. What a multifunctional, a really unique area that's hiding from us, right? So we have a pressor area. So from here we have a projection to preganglionic neurons, exciting them. And the inverse is true for the CVLM, caudal ventrolateral medulla. A similar area of the medulla, but more caudally, that has an inhibitory role. So it does the opposite. Does the opposite. And these are our take-home messages. It's very important that you recognize this. So the more rostral area is sympatho-excitatory, and the more caudal area is sympatho-inhibitory. And of course the IML, those are the actual neurons, the preganglionic neurons. The so-called sympathetic discharge is being orchestrated by these neurons. So that's a node for that main output, because these are the ones that are connected to the ganglia, right? Absolutely. Very, very good. So one example is the baroreceptor reflex. Dr. Bob Johnson is going to describe it, but this is directly taken from Siegel and Saprut textbook. So it's a counter-regulatory response to an increase in arterial blood pressure, baroreceptor input coming into the NTS. The chemoreceptor was similarly on the afferent side coming into the NTS. And then there's an elaborate response on the motor side. In this case, there is sympatho-excitation, also bradycardia. And also, we're exciting respiration. Why? Easy to see. If lack of oxygen, hypercapnia, increased pH of blood evokes this, this is a counter-regulatory response. So now we are getting to this big summary of things that was really elucidated in late 20th century. Bits and pieces have been known for a long time. The main focal point here is hypothalamus. So you see hypothalamus has an autonomic arm. Hypothalamus has another arm going down to brainstem in multiple ways. And it also has a humeral arm through its functions in the neuroendocrine regulation. right? So it certainly has a central role. So we're pointing here. If instead of the blocks, you want to think of brain regions, this is very legitimate and very important to look at and think about it based on what you know about the brain. And then let's wiggle this line. This is an imaginary line between peripheral and the central nervous system. So above this line, we are in spinal cord, and then lower brainstem, higher brainstem, and forebrain. So the rest of the central nervous system, and there's an elaborate central autonomic network of neurons. Again, these are not pathways that we can point to, just like that. But these are intricate interconnections that have their afferents and they have the efferents, if you will. And they have their integration. So once again, even some areas of telencephalon, like insular cortex and amygdala, play critical roles. And then hypothalamus is that main central point. And another huge focal point is going to be the nucleus of solitary tract. As we already mentioned, in the afferent side of things. In the efferent side of things, then you're going to have those vasopressor and vasodepressor neurons, perhaps, in ventrolateral medulla. Again, that makes sense. And then, of course, we are pointing to the spinal cord itself, the thoracolumbar outflow, the so-called lateral horn or intermediate lateral cell column, the preganglionic sympathetic neurons that we talk about, right? And then you can start thinking also in the periphery. We have glossopharyngeal, vagus information coming in, that type of thing, right? Central autonomic network, we ought to recognize it. Even though it's not obvious, but we ought to recognize it. There you go. So all of this is critical information for you to recognize. Autonomic dysreflexia, which is the final slide I have, is a condition caused by an interruption somewhere along this line in the spinal cord. So it's very critical that we understand this. And at the end, I want to show you maybe a handful of clinical illustrations. Congenital megacolon is first. Horner syndrome is a repeat from the hypothalamus lecture because the sympathoexcitatory centers originate in the hypothalamus. And then congenital insensitivity to pain with anhidrosis is a genetic, very rare condition, and autonomic dysreflexia is a post-traumatic condition at the end. So Hirschsprung's disease first, as it's known, and congenital megacolon. This results from the failure of enteric neuronal precursors to migrate. Occurs 1 in every 5,000 births, so not super rare even. And the affected segment, so-called aganglionic segment, is paralyzed in a contracted state. Areas proximal to it get enlarged. The aganglionic is unable to relax, as I mentioned. So that's why it's called megacolon. Anything proximal to it becomes huge. And it can be life-threatening. There's no cure for it really other than the removal of the aganglionic segment. Horner syndrome, we have looked at this under hypothalamus because the signal in fact originates from hypothalamus. It's a sympathoexcitatory stimulus that goes to T1. spinal cord level. And then, of course, via the superior cervical ganglion, the efferents, the sympathetics, use a periarterial route to get into the skull, get into the head. And of course, when this is interrupted, can be centrally, can be peripherally. So can be peripherally, even here. Then what you see here is the absence of sympathetic tone. So the existing parasympathetic tone overwhelms the system. So there is meiosis, ptosis, anhidrosis. Ptosis because there is a tarsal muscle, the upper eyelid, that contributes to the opening. It's also driven by sympathetics. That function is missing. So there are very important central causes of Horner syndrome. Some of our brainstem lesions will cause it, for sure, because it goes through medulla. Again, one of those things that again, pathways that don't stand out, they're hiding from us, and they course through, again, our famous ventrolateral medulla. If there's a lesion, they can be interrupted, and then you have that clinical sign. Or it can be a peripheral lesion. So maybe a stab wound to the neck, maybe gunshot, an arrow, you name it, and then disrupting that communication from the upper end of sympathetic chain. Can it be from a lung tumor compressing in a lymph nodes, cancerous lymph nodes compressing it? Absolutely. Absolutely. Apical lung tumors would be an example. Okay. Congenital insensitivity to pain with anhidrosis. So let's focus on what's missing. So pain sensation is lost, and anhidrosis, so no sweating. So we have a sensory component and we have an autonomic, a visceral motor component. They're both missing. What is based on, this is super rare, it's based on a mutation, or could be several mutations that impair the function of the NGF receptor. So, because the NGF is so important for the development of both the sensory and the motor ganglia, as I mentioned, here's a syndrome associated with it, taking out the receptor. Autonomic dysreflexia, final slide. This is rather common, post-traumatic. In any case of spinal cord transection, and either complete or incomplete, it gets worse and worse as the spinal cord transection becomes more complete at the T6 level or above. What is it based on? This is in fact a failure of that central autonomic network to regulate, because you can imagine if there's a disruption here, so let's suppose upper thoracic, right? So only the central component is disrupted, the peripheral are not. That's the key to the understanding of the syndrome. So the spinal cord is cut, so influences that would regulate the sympathetic tone are lost. So what happens is a dysregulation, an extreme sympathetic activation below the lesion from peripheral receptors feeding back, a so-called sympathetic storm below the segments, and then the body is attempting to counter-regulate by ramping up parasympathetics. So sometimes there is reflex bradycardia, flushing of the face, blurred vision, stuffy nose. So they are all regulatory mechanisms in vain, so to speak, It's usually what happens is that, and what is most dangerous is the spiking of blood pressure. And even an innocuous or physiologic stimulus from the periphery below the segments, such as a distended bladder or impacted rectum and that type of thing, can evoke this, going into this dysregulated state, which is based on the inability of descending inhibitory inputs to restrain the overactivity. So even minor pain, ingrown toenail, some kind of a cut in a paralyzed patient. So it is very important to pay attention to this, to give proper nursing care and proper long-term care to the patients that are in this paraplegic, long-term, post-traumatic spinal cord injury situation. For this reason, it is unfortunately very, very common, and it needs to be caught, and it can be caught by careful monitoring of blood pressure and everything else. All right? So this is called autonomic dysreflexia, and this was my final slide based on the interruption of pathways running between brain and spinal cord. So this is what I had for you today. Well, thank you for your attention. Yes, question?
Is the Hirschsprung disease, is that diagnosed like at birth?
Yes. Hirschsprung's disease is typically diagnosed soon after birth. Yes. Yes. So when you realize there is no meconium in a newborn, they don't have bowel movements, and you start wondering, and maybe their abdomen is becoming distended. Yes. So it's an inborn genetic error. Thank you. Okay, very good, very good. Is there anything else? Okay, thank you guys.